Wonderful. Hello, everyone, and thank you very much for your time today. My name is Catherine Cullen, and I'm a representative of the Community Care Branch. I am joined by my colleagues, Melissa Fromm, Partnerships and Workforce Planning, Parvin Yazdanparast, Infrastructure, and Cameron Symon, Financial Services. And we represent the interdepartmental team tasked with presenting Saskatchewan's position on a national effort addressing the challenges with long-term care. So as you can see our outline today, we will define our issue and cover background, provide draft policy solutions, discuss Saskatchewan's conditions, implementation, risks, and then conclude with our financial commitment and a brief summary. And so the main issue we are presented with is as follows. The federal government is seeking a coordinated national approach to address the longstanding problems with long-term care, which have been further highlighted by COVID-19 pandemic amidst growing public concerns, provincial, territorial, fiscal challenges, and intergovernmental tensions. Canada is facing a new normal we could have never predicted. The rise of retirees and elderly is putting a new focus on policies and government programs. However, the pandemic has highlighted longstanding concerns with one important system for the aging population, long-term care. We need to do better. Our seniors and aging population have weathered war, uncertainty, and immense change, and our language, policies, and programs need to reflect this resilience. Today, we will not only discuss how we want to begin a national conversation, but as well, really ask ourselves, how do we want to age? Right now, long-term care provides support to people of all ages with a high level of complex personal and medical needs. In Saskatchewan, and very similar to across Canada, the majority of people in long-term care are seniors with a significant amount over the age of 85 years old. Special care homes are the backbone of long-term care in Saskatchewan, and these homes are run by the Saskatchewan Health Authority or a contracted operator. And all of these long-term care facilities are regulated through provincial guidelines setting minimum standards of care. And right now, we see the ministry spends about $900 million in long-term care every year, and then about 80% of long-term care cost expenditures are covered by the province, and then the rest are paid by fees. Saskatchewan, as we can see, has 159 long-term care facilities, and 75% of those are publicly owned, 4% are owned by private for-profit, and then the remaining 21% are owned for not-for-profit organizations. And Saskatchewan actually has one of the lowest percentages of private for-profit long-term care facilities in Canada. So in our attempt to mitigate the negative impact of COVID-19 on long-term care, the ministry responded in a variety of ways. So we began by instructing the Saskatchewan Health Authority to review and update H1N1 policies. And the ministry also coordinated an Incident Command Center and Health Emergency Operations Center to ensure collaboration across ministries. We introduced evidence-based policy measures to reduce infection and support the health and safety of residents and staff. And then this group is actually now included in phase 1 of the vaccine rollout. The ministry also instructed the Saskatchewan Health Authority to co-manage Extendicare's facility to control outbreaks. And we look forward to receiving that report from the ombudsperson currently undertaking the investigation. And other provinces took similar approaches and adapted federal guidance to meet provincial needs. And research showed a decrease in the number of COVID-19 cases in long-term care as the policy responses evolved. While our efforts were proactive and significant, the number of deaths is still devastatingly high. And 3% of all COVID cases in Saskatchewan are related to long-term care homes. Those 3% contribute 21% of the total provincial deaths. This data highlights the significant impact COVID has had on long-term care and the vulnerability of populations in the homes.
We are suggesting a new direction on long-term care policy based on the following key objectives. COVID-19 pandemic has exposed long-standing systemic vulnerabilities, and with the demographics of an aging population with more complex and interconnected health issues, the public expects and is increasingly vocal with the government to respond. We should intervene early to maintain public confidence, which will also influence the success of our future efforts to engage the public to design a viable basket of support. Moreover, we want to ensure we are offering patient and family-centered care. Our services should adapt based on changing desires, and currently there is growing need for robust home and community care services, an alternative form of support for care recipients and also their unpaid caregivers. Another objective is to minimize both the short and long-term risks. We intend to minimize the impact of COVID-19, the risk of future outbreaks, and ensure the appropriate resources are in place for the future. As we plan for the future, we want to assess the opportunity cost of our decisions to ensure a cost-effective and sustainable senior strategy. Currently, what we are observing across Canada is an institutional model for long-term care. These institutions tend to bring residents together who are older, frail, and have a myriad of underlying health conditions. Care in these settings is delivered in close proximity, often within confined and shared places. Research and experts tell us that there is a range of services that could provide the same care for high needs-based care through home and community care. This would take a new perspective, one that we believe Saskatchewan is ready to start. Now we are going to explain some of the reforms to the current institutional system we are proposing.
These reforms will result in a fundamental shift in the way we fund and operate supportive care programs. We're now going to highlight 3 areas where we can make actionable change: the move to a value-based supportive care system, rethinking how we build and design spaces, and where we get the staffing necessary to meet the demand. Value-based healthcare means measuring outcomes that matter to patients and comparing them with the associated costs to inform decisions on program and service delivery. We think Saskatchewan already has some of the tools to move to a more value-based system, like patient and family surveys, the Canadian Institute for Health Information Reporting, and the intent to move to inspections in long-term care. However, we need to continue to make accessible data a priority to steer future funding decisions. In practice, a value-based system may mean cutting poor-performing and high-cost programs and transitioning that investment to successful models. This seems like an obvious thing to do, but often programs become institutions and have little evidence they're valued despite being around for a long time. This is what led to the institutional model of long-term care. For example, we are suggesting moving to smaller residential facilities instead of the large institutional ones we have today. According to a recent report released by Australia's Royal Commission on Aged Care, Quality and Safety, facilities with between 1 and 30 beds scored the best on a significant majority of the quality and safety indicators they measured.
Adopting these reforms means taking a serious look at the current infrastructure because many of these large facilities would become obsolete. To implement this transition, while we will review the maintenance needs of the existing facilities, repurpose building any new ones, we think it would be preferable to have the facilities owned and maintained by the private sector, with the public sector providing the care. Private sector could build the facilities needed swifter, and private ownership reduces the risk that at the end of the baby boomer generation, the public sector possesses significant infrastructure investments that may no longer be needed, whereas the private sector could more easily turn these facilities into private assisted living or housing. The federal government has announced significant investment to move to a green economy, which includes over $33 billion in green infrastructure over the next decade. We believe there is opportunity for us to take advantage of this vast range of programs in our short-term COVID-19 planning, as well as our transition to residential care. A new temporary COVID-19 resilience stream has been created to support repairs and upgrades for provincial buildings and health infrastructure. Moreover, infrastructure investments are key to creating jobs, and these new home-like environmentally sustainable buildings will not only improve the everyday lives of the care recipients, they also facilitate the economic recovery post-COVID-19. Staffing demands are likely to increase relative as new beds are added to the system. In the home-like model that caters to low to medium needs clients, staffing is likely to be more focused on care aides and licensed practical nurses, thereby allowing medical staff such as registered nurses, nurse practitioners, and physicians to cover multiple homes in an area. In addition to special federal immigration pathways, the federal government has implemented an initiative to rapidly train 4,000 care aides. Given Saskatchewan's largely publicly operated supportive care sector, wages are high compared to other provinces, which gives us a competitive edge to access new labor. We believe the following 2 major conditions need to be met by the federal government to engage the provinces and territories towards a national coordinated approach. The first and foremost condition is ensuring sustainable funding is available. Only under this circumstance, the province will be able to bring in fundamental change and leverage this national conversation to repurpose investments with a longer-term horizon. In absence of sustainable funding, the responses will be scattered, and the system becomes more vulnerable to changing political climate. Due to the varied combination of issues between jurisdictions, there is not a one-size-fits-all solution, and maintaining jurisdictional autonomy is necessary to meeting local needs. For provinces to take advantage of their existing resources to address the fast-changing citizen demands, they need to have the flexibility to build on their strengths and target their efforts on their shortfalls. While provinces have agreed that funding is needed, Atlantic provinces have shown interest in developing national standards, and compared to other provinces, they seem to be inclined to receiving additional funding in price of losing jurisdictional autonomy. We anticipate severely impacted provinces and provinces with higher percentage of privately run facilities such as Ontario, Quebec, BC, Alberta, and even Manitoba will be more resistant to reforming the system, as they have previously also opposed losing autonomy.
We know our current approach to the delivery of seniors' long-term care in this province isn't sustainable from either a capital or an operating perspective. There's an opportunity to use the current focus on elder care to create true systemic change. With the aforementioned conditions in mind, we considered how to best move forward with a request for funding from the federal government and a national strategy that would allow us to retain our autonomy. We considered establishing a new long-term care transfer and a regulatory governance board, but ultimately we decided to propose early renewal and renegotiation of the existing home and community care bilateral agreement and the establishment of a royal commission to review elder and long-term care across the country. Knowing that there's a need for sustainable and transformative funding for our elder care systems, an option that would provide immediate and long-term relief is the renegotiation of the existing bilateral agreement. We would suggest an arrangement that spans a period of 20 years in order to bridge the costs associated with the aging baby boomer generation. The allocations to each province would be based on population. Our province is already committed to the ongoing funding of elder care, hiring new additional care aides, and investments in new infrastructure. And we believe we can leverage those commitments to secure funding through a bilateral agreement from the federal government to equal approximately $28 million per year in new funding. The benefit of this option is that an amendment or an early renewal of an existing bilateral agreement could be quickly enacted to meet the immediate and ongoing needs identified during the pandemic. Additionally, a bilateral agreement would signal a shared intent to address this important issue. The drawbacks are that this funding is less flexible and bilateral reporting can be time-consuming and onerous. Renegotiation would be necessary at the end of the term. With regards to the federal call for a national strategy, our recommendation is that we request the federal government establish a royal commission under the Inquiries Act to review provincial elder and long-term care systems. The COVID-19 pandemic has highlighted significant deficiencies in the way that we care for the elderly and infirmed in our country. We believe this is a matter of great importance that warrants the authority and the thoroughness that a royal commission would bring to the issue to establish a holistic standard of care. Similar to the Australian Royal Commission into Aged Care Quality and Safety, this commission would serve to seek public and expert feedback and to further engage and educate our population on the current status of elder care. It would publish associated research reports and culminate in a publicly releasing formal findings and recommendations for a universal standard of care for the country. The most recent Canadian Royal Commission for Truth and Reconciliation took 5 years and approximately $60 million to complete. We believe a royal commission on this topic could be completed in a 3-year timeframe for approximately $40 million. A royal commission would not infringe on our provincial jurisdiction and would serve to engage and educate the general public. The final report would help to guide future strategies and assist to establish a standard of care that would help the general public to be better informed on their own standard of care. The establishment of a royal commission would display to the country that all levels of government have a strong desire for the improvement of care for our aging citizens. There is a chance that the federal government might be seeking more control and involvement than a royal commission would provide them with. But again, retaining our jurisdictional authority is a key condition of engagement for us. Recognizing the Council of Federation's push to make a Canada Health transfer equal 35% of total health expenditures, an alternative option for funding that we considered is the creation of a new transfer that would make up some of the difference between what the CHT currently covers and a targeted 35%. This would provide the provinces with stable, long-term funding for supportive care services that is established through legislation. It would certainly be more feasible to agree to universality and standards of care with long-term stable funding like this in place. The drawback is that because a transfer has to be established through legislation, it would not be in place quickly to assist with current urgent needs. And there is a risk that funding would not keep pace with the growing financial needs related to elder care for the boomer generation. An alternative to the Royal Commission is the creation of a permanent national organization founded by the provinces, territories, and federal government to provide oversight of long-term care operators and regulators in Canada. This organization would function like the Canadian Agency for Drugs and Technologies in Health and would establish best practices and standards of care. It would have independent evaluators who would audit long-term care facilities and other elder care provisions throughout Canada and would publish publicly available reports on the quality of care being received. A benefit of this option is that it would certainly increase accountability of individual provinces and care providers. However, it would be time-consuming and challenging to establish this body, and the desire for autonomy coupled with jurisdictional differences would make it very difficult to establish a one-size-fits-all standard for the entire country.
The two largest risks we see associated with the Royal Commission are that the Commission brings some negative publicity to the state of long-term care in Saskatchewan and throughout Canada. We are fairly confident in the state of Saskatchewan's system compared to other provinces, but should be prepared to address some difficult issues. Other provinces with much higher for-profit long-term care could face significant lobbying from private operators. Each province will have to consider the message they want to send to the public if they refuse to engage with the Commission or don't take its recommendations seriously. The two greatest risks we see associated with renegotiating the bilateral agreement are that we could fail to negotiate stable transfer funding with the federal government in the future. We think that the federal government understands the fiscal situation the provinces are in, but even without transfer funding, we hope to have a more cost-effective solution for long-term care in the future by adopting our reforms. Provinces may not use the opportunity of a renegotiated bilateral to make the necessary reforms and instead fall into old institutions. We think that in the absence of being able to exert direct influence over jurisdictions, we should simply lead by example and establish our own high-quality long-term care system. Saskatchewan is making investments to try and meet the demands of the aging population. We're investing $122.4 million in staffing infrastructure in the near-term future, and these investments are a good start. But according to the Conference Board of Canada, Saskatchewan's demands for beds will increase by about 4,700, or just over 50% of the current number, over the next 15 years. At today's prices, these beds would cost between $1.5 and $2 billion to build, and about $376 million of government funding to operate. The costs associated with building and operating these beds will provide good paying jobs in the province. Saskatchewan will gain from both the direct and indirect employment engaged GDP. Several hundred people per year will be required to build this infrastructure, and thousands more will be needed to provide the care. In the immediate future, Saskatchewan should address the pandemic concerns, such as 3 and 4 bed rooms and old ventilation systems in current infrastructure, renegotiate or sign the bilateral agreement to support the expansion of home care and operation of smaller residential facilities, and promote the federal care aid training program to Saskatchewan residents and work with the Saskatchewan Health Authority to find them work placements. In the short term of the next 1 to 3 years, Saskatchewan should work with the private sector partners to build, own, maintain the smaller residential facilities, while the public sector or nonprofit sector provides the care, and then engage with the Royal Commission and learn promising initiatives. And finally, review the Ombudsman report on the private for-profit parkside extended care concerns and address the recommendations. In the long term, after 3 years and into the future, with significant demand for aging care, Saskatchewan could continue pushing the federal government for stable transfer funding, and then operate the new residential facilities and monitor outcomes. So in closing, we reconsider the question, how do we want to age? And what should the provincial response be during a time when the public's faith in the long-term care system has been shaken? Ultimately, we support a national effort to improve the quality and standards of long-term and aging care, but we think that we need to re-examine the institutional nature of long-term care and move towards more home and community services and outcome-based funding. And we think that in order to move forward nationally, the federal government must increase its contribution to health funding and respect our jurisdiction. Thank you, and we now take questions.
Well, team, thank you very much for that presentation. I'll turn now to questions from the panel, and I'd ask in your responses, team members, if you could keep them concise. That enables us to ask more questions. Because we're very interested in what you've had to say to us. So I'll start with Janine Richaud.
Thank you very much for the presentation and the well thought out considerations before us. I have a question though about the Royal Commission. The Prime Minister has made it very clear that for the federal government, immediate action is needed now. Not adverse to more funding, but definitely with conditions attached. I'm just not sure how you think you're going to be able to get increased funding from the federal government with a commission, with a recommendation of a commission, which, let's face it, you said it yourself, the Truth and Reconciliation Commission was 5 years, and you haven't even calculated that we've not implemented all of those recommendations yet. So what is it about your proposal that makes you think the federal government would be willing to give more money to provinces for no more than a commission, which will take years to tell us what national standards should be?
Oh, great question. You know, I think that's really where the bilateral side of our proposal comes in. And that's where I think we really have the opportunity to have the autonomy and the more targeted approach of provincial jurisdictions. And I think we know, as we've observed what has happened through the COVID pandemic, that there's been different systemic problems in different provinces. And I think that going with the bilateral that allows for sort of unique solutions in each jurisdiction is where we'll really see that immediate response while we wait for additional information that allows for us to have a more targeted national approach.
Okay, thank you very much. Steve Orsini, question to you.
Yes, so thank you for the very professional presentation. I'm just thinking about how the bilateral agreements evolved over time and way the federal government was dividing and conquer provinces. So I'm thinking about your strategy and your reference to the Council of the Federation, which was an important reference to getting up to 35%. And why I want to relate that to your bilateral agreement. Are you looking for a comparable increase in the bilateral agreement as the Council of the Federation was looking overall? I'm trying to relate your slide 14 to the overall ask from provinces. If you can respond to that, it'd be great.
So in order to meet the 35% target that is asked for by the Council of Federation, it would be about a $700 million increase in Saskatchewan, just for Saskatchewan, taking into consideration. For the bilateral, we kind of looked at where can we access new funding in the immediate term, and so our numbers were just an increase of a doubling to access new funding in the future. So the bilateral, as we suggested, would not meet that 35%. I guess we would encourage those discussions to continue to occur. Saskatchewan's health expenditures are increasing, and the federal government's contribution will actually decrease in the next couple of years. So we still would like transfer funding to occur, but this bilateral is kind of an immediate solution.
Okay, thank you. Other comments or questions from the panel? I've got one while we're waiting for others. You put a lot of faith in a Royal Commission, and maybe I'm just a jaundiced federal observer, but Royal Commissions can take a long time. Sometimes they work, sometimes they don't. Sometimes they just reinforce the status quo. Can you tell us why you think a Royal Commission is the right way for Canada to address this important problem? My colleague already talked about the timeliness issue, but really, aren't you just putting a lot of faith in something, kind of something magical showing up under the Christmas tree?
I think there's a few facets to the Royal Commission that we see as valuable. I don't think that we can understate the value of better educating the public. I think that even the public themselves would probably acknowledge that there's been a degree of complacency as the consumers of long-term care. And as we've watched, particularly in the last 11 months of the pandemic rolling out, it's brought the issue to the forefront. And I think it's advantageous for the consumers and for us as a province to continue down that road of keeping it at the forefront of the public's mind. And then further to that, I think sort of the other piece that I think makes the Royal Commission really advantageous for us is that it keeps it at the forefront of the federal government's mind, and it in some ways puts the burden in their ballpark. That is, we roll out a Royal Commission and we better educate the public, and we start to find areas of opportunity and need. Their hand may be somewhat forced to continue to engage and sit at the table with us as we want to talk about health transfers and the potential for a long-term care transfer and renegotiating bilateral agreements.
Okay, thank you very much. Turn to Susie McDonald.
So thanks again for the presentation. I think what I understand here is you're moving towards bilateral agreements because you don't think that a national standard is what's needed. You're making some recommendations for some very innovative things within your province, private nonprofit partnerships, public partnerships, really changing the way you do business. Would you tie your implementation to those bilateral agreements? And do we want to be held hostage to the federal government in terms of our own changes internally?
Who wants to take that?
I was kind of pausing. I just didn't want to answer all the questions, but I'm kind of the bilateral girl, I guess.
Okay, go ahead. Yeah.
You know, I think, you know, in terms of looking at measurable outcomes, and yeah, for sure, anytime there's money coming down from one level of government to another, there's going to be some expectations and some outcomes that we have to commit to. That said, you know, I think that we shouldn't shy away from that, and that we should want to be able to meet a minimum standard of care. With regards to potentially establishing a federal standard of care of some sort, you know, I think, again, to that Royal Commission, and as we start to uncover where some of the deficiencies are, and if there is opportunity to establish some standard of care across the country, I think it'll be some time before we have the data to really know what that looks like and whether that's something we as a province can commit to.
Okay, Janine Richaud.
Thank you. I'll ask another question so there's still a little more time. Kind of following up on Susie's question around, it seems that you guys are not in the zone of believing in national standards. So my question is simply, why not? There are mechanisms, interprovincial mechanisms. The Canadian Free Trade Agreement set up a regulatory reconciliation and cooperation table that precisely brings provinces and territories together to work on labor mobility and economic regulations and develop exactly this precise kind of a thing. Wouldn't this be a great project for a table like that at a time like this?
I can jump in here. So just thinking about the short term, what we see is just, first of all, not a lot of data pointing to specific provincial needs, but we do recognize that each province has a diverse amount of needs that need to be met. And we feel like in the short term, knowing that we're battling with COVID, that each province should take that on themselves, making sure that they're ensuring that they're meeting the needs of their particular province.
Can I come back with another one? And the floor is open to my other colleagues. As you know, in our province, in Saskatchewan, we have, as you pointed out, we have overwhelmingly public facilities, and we're almost unique in Canada in that. And yet, do I understand correctly that what you're proposing is that the new build and the new construction and the shift should be toward more privately owned facilities because of the flexibilities that you say that gives us? Is that right? And what do you think the people of Saskatchewan will feel about such a major policy shift with respect to long-term care homes?
So for the new facilities, we're thinking mostly about the home and residential care facilities. We think that the private sector could build more swiftly to be able to address the rising demand. But for the existing facilities, we actually think that it is one of our strongest points that we already have a high percentage of publicly owned facilities that we're going to maintain. So we will keep the institutional model, but as we transition to more home and community services, we think that private sector could own these facilities and build them swifter. And also there would be a risk of us possessing a large number of facilities that we might not be able to liquidify these assets later. Right. So we believe that this would be a risk in the future.
Okay, thank you. Steve Orsini, last question to you.
Thank you. I just want to follow up on that response, because when I look at the terms of reference for the Royal Commission on the Future of Supportive Care and the whole discussion on long-term care, which is the institutionalization of elder care, is the idea to look at a more broader solution, as you talked about, as opposed to looking just at institutionalizing our seniors?
Yes,
Yeah.
that's exactly it. Oh, sorry, Catherine.
It's okay.
No, go ahead, Cameron.
Okay.
Go ahead.
Yeah. So the reason we titled it supportive care is we'd be looking at really the whole continuum of care for not only just the elderly, but also, you know, lots of younger people with disabilities access current long-term care systems. So the commission would really go and talk to individuals affected by this and ask, what would you like to see in a supportive care sector? Institutional long-term care might be good for some high complex individuals, but home and community for more people who can live independently. So yeah, we would like the commission to really take a broad look at this issue.